Our next speaker is Gigi Chen. Dr. Chen is a cancer specialist in gynecology and a medical oncologist at Diablo Valley Oncology. Welcome, Dr. Chen.
Thank you, Margaret, for the kind introduction. It's my pleasure here today to give you an update on ovarian cancer treatment as well as gynecologic cancer survivorship. And I thank you all for being here this evening. So, who is a cancer survivor? An individual is considered a cancer survivor from the time of diagnosis through the balance of his or her life. Family members, friends, and caregivers are also impacted by the survivorship experience and therefore are also included in this definition. Dr. Lerner had talked to you about ovarian cancer epidemiology. In 2012, we estimated the new cases about 22,280, and estimated death from ovarian cancer is about 15,000. The 5 to 10% of ovarian cancer are familial, and those can include familial inherited ovarian cancer alone, or ovarian cancer and breast cancer, or ovarian colon cancer. And Margot will talk to you more about the hereditary cancer syndromes. So in the gynecologic cancers, uterine cancer is the most prevalent, meaning that there's most cases diagnosed, and then followed by ovarian cancer and then cervical cancer. Vulvar and vaginal cancer, that each comprises about 3%. Amongst the gynecologic cancer deaths, ovarian cancer is harder to treat and it comprises more of the cancer deaths than the uterine cancer and cervical cancer. So I want to briefly talk about the staging of ovarian cancer. Stage 1 ovarian cancer means that the cancer involves one or both ovaries. See if I can use this pointer here. And stage 2 ovarian cancer is that the cancer involves ovary, but there's also a pelvic extension. In stage 3 ovarian cancer, there is peritoneal deposits or metastasis, so as you can see here. And then stage 4 ovarian cancer means that the cancer has spread to another organ, which can include the lung, the liver, or the bone, or other organs. So the treatment of ovarian cancer really takes, it's a combined effort between the patient, their family, as well as multiple providers. So we start out with a diagnosis of the cancer that's usually made by either the patient and the primary care physician or an OB/GYN. And then the patient will see a gynecologic oncologist for evaluation for surgery. And if it's determined that one can have an optimal debulking, meaning remove all the visible cancer, then then she would undergo the surgery, and then after the surgery, discuss with the gynecologic oncologist as well as medical oncologist about further treatment, which would include chemotherapy or a combination of chemotherapy and targeted therapy, and also looking to possible clinical trials as well. Then after the treatment, after the chemotherapy, or what we call adjuvant chemotherapy, we do very careful surveillance that would include physical examination, gynecologic examination, and tumor marker checking, including CA-125. If there is evidence of cancer recurrence, then we would need to go back to do more chemotherapy, either a similar chemotherapy or a different type of chemotherapy. So chemotherapy are drugs that will either kill cancer cells or stop cancer cells from dividing. And there are many forms of chemotherapy, including intravenous chemotherapy, or oral chemotherapy, or chemotherapy that's delivered intraperitoneal with an intraperitoneal catheter. And there's also another concept of targeted therapy, which is a type of treatment which the drugs can attack cancer cells more specifically, and in that way we can hope to minimize the side effect to normal cells. So one example would be bevacizumab, which is Avastin, and that is a monoclonal antibody which stops the production of the blood vessels that feeds the cancer. So that is one of the ways that we would use in the treatment of ovarian cancer. Another type of targeted therapy is called a PARP inhibitor, and that is a type of a drug that can block the DNA repair, so that can cause cancer cell death. So over the past many years, you can see that there has been many chemotherapy drugs that's used in the treatment of ovarian cancer. We can date back to all the way to 1964, where first drug was used was melphalan, although I have never used melphalan in treatment of ovarian cancer. Then some of the common drugs, including carboplatin, developed in the 1989, cisplatin, also paclitaxel in 1990s, and other drugs including topotecan, liposomal doxorubicin or Doxil, Gemzar. So there have been a lot of research in terms of finding out what is the best drug and also finding out what is the best delivery modality in order to have the best outcome in the treatment of ovarian cancer. One of the classic clinical trials that was done was called GOG 172, and that was a clinical trial that was actually done back from 1998 to 2001, where they accrued 416 patients, and these patients have a stage 3 ovarian cancer, underwent surgery. Patients are randomized into two arms. One is intravenous chemotherapy alone, or a combination of intravenous chemotherapy as well as chemotherapy delivered in the peritoneal cavity. What was found was that the combination of intravenous chemotherapy as well as intraperitoneal chemotherapy afforded a longer overall survival for the patients on the study, and actually a difference of about 16 months, so quite significant. And this is a chart that we use in the cancer studies, and it's called Kaplan-Meier chart. And the higher the line is, the better the overall survival is. So the top line is intraperitoneal as well as intravenous chemotherapy, where the bottom line is intravenous chemotherapy alone. And we also were talking about newer agents, such as the targeted agents. So the mechanism of Avastin is there are these vascular endothelial growth factors that are floating around in the bloodstream. And Avastin is an antibody which can be delivered in the bloodstream and catches these vascular endothelial growth factors, so inhibit the production of the blood cells, so cancer has less blood supply to feed onto, and that can result in the cancer death. So more recently, there was a pretty large clinical trial that was conducted nationwide, and it compared intravenous chemotherapy with the traditional drugs that we would use, the carboplatin Taxol, compared that to a combination of the chemotherapy plus Avastin for the usual 6-cycle duration. And the third arm was chemotherapy plus Avastin, but also included keeping the Avastin for another 16 cycles. And the goal is to see if there's differences in terms of the cancer control, whether it keeps the cancer away for longer, whether there's any impact in terms of how long women live, with these different treatments. And what was seen was that the combination of the chemotherapy plus the Avastin offered a modest progression-free improvement interval, for about 3 to 4 months from this study. Overall survival currently, we don't see much difference in the 3 arms. However, patients, if they have a recurrence of the cancer, they go on to receive many other treatments. So there are a lot of debates of, why that's the case. So we talked about delivering the drug both in the IV as well as intraperitoneal. That seems to be a good result. We also talked about the Avastin. And what about combining those together? So there has been a recent trial which actually has just finished accrual, and I know some of my patients are on that study, which compares the intravenous chemotherapy plus Avastin, to intravenous and intraperitoneal chemotherapy plus Avastin to see which arm would offer the most control of the cancer and offer the best survival. So we'll await the result of that trial back. Okay. If we look at the history of ovarian cancer, initially patients have a diagnosis of cancer, they undergo surgery, and then patients are observed, and this is what we call a surveillance period. We can see that ovarian cancer can come back, and there is a difference between the rise of the CA125 to clinically we actually see disease coming back, or women have symptoms, or on the CT scan there are actual evidence of the cancer. And that lag can actually be quite a few months. If they have a clinical recurrence, then we usually start the second-line or third-line chemotherapy. Another newer drug, class of drug that's being investigated is something called a PARP inhibition. And the PARP inhibitors are a class of drugs that can affect the DNA repair. So normally, in order for cells to replicate, we have our DNA repair mechanism. So it repairs the breakdown DNAs. However, there are certain cancer cells which may have a more difficult time in terms of the repairing the DNA. And one of that example we see is in patients who have the BRCA mutations. And in these patients, they do have a deficiency in terms of the DNA repair. And also we see that the PARP inhibitor may work better in this population of patients, so which may be able to offer us some ability in terms of selecting which patients will benefit better from certain therapy. And this, I apologize for that this being a very difficult to read slide here, but what it shows is that this is a clinical trial which looked at a PARP inhibitor, olaparib, compared to placebo in the setting of recurrent ovarian cancer. And what it did show was that there was activity in the PARP inhibitor compared to placebo in terms of prolonged disease-free interval. And when they looked at it, they actually found that it's more sensitive, it's more pronounced in the patients who have the BRCA mutation. So my vision is that, hopefully we can use the tumor molecular profile as well as the patient, profile in terms of selecting therapy. We're not quite there yet. However, my vision is that in ovarian cancer patients or other gynecologic cancer patients, endometrial cancer patients, traditionally we have been treating all patients the same way. After the surgery, we give them the standard chemotherapy, and then if there's a recurrence, we give them additional chemotherapies. However, the individuals are different. And the patients can have different molecular profile. Some can be in the group, a blue mark here, and others can have specific molecular profile, such as the BRCA mutations, for example, if they could be the ones that are in yellow, and hopefully we can use these different molecular profile and separate out and individualize treatments for our patients, and that will offer a better efficacy as well as hopefully decreased toxicity. So I think that's what everybody wants to work towards in terms of finding targeted therapy, finding newer therapy for our patients. So there are a number of long-term effects of the treatments, which can include cancer-related fatigue, pain, weight gain, depression, anxiety. There's a concept called chemo brain, and also inability to work or loss of employment. Certainly can affect our interpersonal relationships, changing the personal relationship. Therefore, I think for our cancer survivors, it's not just that you live, it's how you live. That's very, very important. And we emphasize a healthy lifestyle. Chin will talk to you about a nutrition aspect of the cancer survivorship, which is very, very important. We also have an oncology rehab service at our cancer center as well, where we emphasize physical therapy and has a personalized workout program. And we really emphasize exercise, stay active, because that can reduce cancer-related fatigue, that can reduce anxiety, depression, improve mood, boost self-esteem, and also reduce nausea, pain. There have been lots of studies looking at that. So with that, I thank you for your attention, and I'll be available to answer questions afterwards.
Thank you, Dr. Chen. So if you have questions on the blue cards for Dr. Chen, if you would raise them up in the air, and folks will come around and collect those. Our next speaker is Margot Thielander, who is a board-certified genetics counselor with John Muir Health. And questions for Margot should be written on your pink